All right, guys, can you hear me?
Yes, I can hear you, Dr. McClung.
Okay, great. And I'm just going to jump in and get started because it's going to be hard to finish in time.
Okay.
So let me just close this. If you guys have any questions, feel free to unmute and just ask as we go along, and then we'll go from there. So welcome. This is a 2020 LLSA that we're presenting. ABEM allows us to review the material, including the questions, but not the specific answers, in a live format. And that's something that Vituti hosts on a webinar. Since I'm doing this directly through Palomar, I can't display what the questions are or discuss the specific answers, but we can discuss the articles, and by going through that, create a file that is a good review that can be obtained at any time, as opposed to the intermittent times that the live webinar can be provided. So that way people can prepare and pass the test at any point, irrespective if they have the questions in front of them or not, because we're going to cover the material that's relevant. So there's 13 articles. The first article is by Acri and Davis, looking at acute diarrheal infections in adults. This is a sponsored study by the American College of Gastroenterology and looks at particular recommendations that are applicable to acute diarrheal infections, excluding those that are related to C. diff. So C. difficile is not included in any of these particular recommendations, and they note their recommendations based on levels of evidence. So they have high level of evidence, moderate level of evidence, and low level of evidence. And we'll just quickly review what those summaries are. So the first summary for high level of evidence and strong recommendation is that antibiotics are not recommended for mild traveler's diarrhea or for routine diarrheal infection. The authors note that norovirus is the most common cause of gastroenteritis and is associated with about 26% of cases that are diagnosed in the emergency department. However, they represent 90% of deaths occurring in people of age over 65 who are dying from diarrheal illness. In addition, bacterial agents that are amenable to antibiotics are infrequently determined from regular routine emergency department use. So the presence of Shigella, Salmonella, Campylobacter, and so on and so forth are only found about 9% of the time. So there's really not a high yield in terms of getting that information from routine ED basis. Therefore, there's not a level of support to provide any antibiotics, and particularly when you consider there are some negative side effects and risks of hemolytic uremic syndrome and kidney disease and a number of those different agents. Now that contrasts significantly from patients who have traveler's diarrhea, where upwards of 50 to 94% of the patients with traveler's diarrhea have an identifiable bacteria, and therefore those that have moderate to severe symptoms should be treated with antibiotics. And the recommendation is to treat them with azithromycin over quinolones. And the azithromycin dose is just 500 milligrams daily for 3 days. And that's beneficial over quinolones because quinolones are more associated with causing C. diff in a post-antibiotic state. So that's a moderate recommendation for them, that if a patient has disabling traveler's diarrhea with moderate to severe symptoms, that they should be treated with azithromycin 500 daily for 3 days. And in addition, they note that adding loperamide with the antibiotic further helps to enhance and reduce the duration of the symptoms and bring about a higher percentage of cure. So again, that's for patients who have moderate to severe disease, should have that as well. Now the moderate level of evidence says that there's no support for probiotics or prebiotics, and they're not recommended unless the patient is presenting with a post-antibiotic diarrhea. And so in those circumstances, there is a low level of evidence recommendation for that. There's really not a lot of support that probiotics or prebiotics bring about any significant degree of intestinal health improvement in that immediate period. And if anything, in comparison to the other options, and particularly for those that have C. diff, we see that stool transplant has much higher effect and efficacy of improvement in those cases, then followed by antibiotics, and probiotics again might have a minor role. Now, there's a low level of evidence for cultures and the methods of cultures of using PCR testing if the patient is symptomatic with moderate and severe symptoms and has been having diarrhea for more than 7 days. So that allows a more specific identification of the organism that's involved. However, that technique is considered a culture independent method because you're not necessarily growing the bacteria and then becoming aware of its specific antibiotic sensitivity. You're just identifying the genes and determining which variant of bacteria is causing this in specific strains that are involved. They do recommend, though, of performing cultures if the symptoms have been going on for more than 14 days and stressing that those cultures should include cultures specifically for parasites as well. And so that's the overall summary of the recommendations from the American College of Gastroenterology in this paper. Are there any questions about this? And I'll try to. Sorry, I can't. For some reason, I can't see my cursor, but that's all right. We'll just move on. Just unmute yourself if you have a question, and I'll be glad to stop and answer. So the next article, so the second article is on acute myocardial infarction. This is by Dr. Anderson and Dr. Moreau. And this is a really great review of the topic of myocardial infarction. And they go through the pathophysiology and looking at the differences between acute coronary syndrome that is related to acute thrombosis versus a supply-demand imbalance and essentially an acute myocardial infarction that's related to rate-related ischemia or some other form of ischemia, either due to lack of hemoglobin or so on and so forth. So the first issue is that the patients are presenting with ischemic discomfort, and the determination is whether or not this is acute coronary syndrome, either related to a partially occluding thrombus, in which case you won't see ST elevations, and obviously with those that are having complete occlusion, you'll see ST elevations, and biomarker levels may or may not be elevated on initial testing, and we refer to that as a type 1 STEMI, which may progress to a transmural infarct if not acted upon quickly enough. Whereas those with partial occluding thrombus will present with persistent pain, discomfort. If they have increased biomarkers, we define that as a non-STEMI, and again, that can progress without treatment to a non-Q wave MI. So we won't necessarily see transmural infarct. However, if the vessel's proximal enough, that partial occlusion can actually lead to transmural infarct too and see Q waves later. So there's obviously a greater importance, particularly on those that have ST elevation, to have immediate PCI and or consideration of emergent CABG to following PCI, or just actual intervention with angioplasty and stenting with drug-eluting stents. There's urgency in those that have persistent pain and discomfort that are non-ST elevation MIs. As I mentioned, they can still progress to a transmural infarct. So therefore, if somebody's having uncontrolled pain and demonstrating hemodynamic instability, irrespective of the ST elevation, that we still prioritize an acute intervention. Now that's to differentiate it, however, significantly from those where there's no increase in the biomarker level, there's intermittent pain and discomfort, and represents patients with unstable angina, where there is a thrombosis-mediated event that's occurring and spasm that's occurring, but it's not necessarily leading to risk of a transmural infarct, and therefore, without causing transmural infarct, it's less likely to cause significant ventricular dysfunction. And as a result, it's amenable to treatment at a later stage. So there's not as much urgency to get the patient to the lab within 90 minutes for that. And they have anywhere from 12 to 24 hours before they should, before they can be treated. And there's been no significant differences seen in outcomes as a result of that planned procedure as opposed to the emergent procedures that are done. Now, again, all this differs significantly from those that are presenting with acute myocardial ischemia related to non-thrombotic plaques. And again, there'll be an absence of ST elevation. If there's an increased biomarker seen in these, that's considered a type 2 non-STEMI, and those don't progress to Q-wave infarcts and are amenable to a risk stratification approach and delayed PCI if necessary. And then obviously those patients that don't have any increased biomarkers, the troponins remain negative, go down a strict risk stratification path. When we look at this, their authors give a suggestion for 6 initial assessments and management decisions that pertain to somebody who's presenting with chest pain and possible acute coronary syndrome. The first is to triage them to an acute coronary syndrome pathway and identify if they're STEMI, non-STEMI, possible or probable unstable angina, or if this is a non-ischemic chest discomfort based on their history exam, ECG, and troponin results. And the recommendations are to get an ECG within 10 minutes to get the troponin results, to get the history exam done as quickly as upon arrival as you can, and then send off the labs. The second recommendation is to assess for cardiovascular death and or recurrent ischemia and determine if they're high, intermediate, or low risk based on their clinical features, their ECG, the troponin testing, and integrated risk scores, whether you're using a TIMI score or GRAY score to do that. And then initiating general care, limiting their activity, administering aspirin, nitroglycerin, statins, in consideration of oxygen, beta blockers, and morphine. Now, that doesn't mean that we're going to throw everything at them in their initial general care immediately. That initial general care is actually spread out over the first 24 hours. So the immediate, immediate agenda is to place them on aspirin, and then if they're having persistent chest pain, give them nitroglycerin in consideration of possible anticoagulation therapy. The idea of placing them on a statin can be delayed to some point within the first 24 hours of admission, as is the same issue with beta blockers. And that the consideration of oxygen is really only emphasized on those that have an O2 set that's less than 90%. We know that hyperoxygenation may lead to increased secondary injury from reperfusion events. And so therefore, there's really not a lot of support for just administering oxygen unless somebody has a significant hypoxia to begin with. And then choosing invasive or non-invasive initial strategies is dependent upon those initial results. And early invasive management is based on the risk and patient's preferences. The fifth issue is selecting a second antiplatelet agent to add to aspirin. This is, again, something that is seen with a certain heterogeneity in the practice of cardiologists. There are a number that will suggest going ahead and loading the patients up on Plavix prior to PCI, and there are others that will load somebody on an additional antiplatelet agent following PCI. So the support about doing that before or after has some controversy to it, and there's not an absolute definitive decision that you have to do it before you do PCI. But you should at least be aware that that is it's a consideration, and wouldn't be unreasonable to start them on a loading dose. And then 6 is choosing an anticoagulant agent, either unfractionated heparin, low molecular weight heparins, Lovenox or fondaparinux, or bivalirudin, according to the initial management strategy of invasive or non-invasive and what their underlying risk of bleeding is and their underlying health in terms of whether or not they have good kidney function or not. So when we look at this, a therapeutic target in a condition of a myocardial supply-demand mismatch, right? So you can think of this as like the rate-related ischemia or the intermittent unstable angiospasm without ST changes. That you only administer oxygen if the saturations are less than 90%, and authors really stress that over and over on this in this paper. Analgesics such as morphine can be given for persistent ischemic pain. Nitrates are recommended for the first for 3 doses every 5 minutes. Beta blockers, an oral beta blocker can be started in the first 24 hours. Calcium channel blockers could also be used when beta blockers aren't successful or if they're contraindicated. And then for those that are having acute coronary thrombus, to give antiplatelet therapy of aspirin with an initial dose of anywhere from 162 to 325 milligrams, followed by a similar dose of 81 to 325 daily indefinitely, and adding a second non-aspirin antiplatelet therapy, such as either Plavix or Brilinta or there's one other one that I'm forgetting its name right now, but it'll come to me. And then in addition, anticoagulation therapies administered an intravenous anticoagulation agent to all patients, irregardless of the treatment strategy. And then for unstable atheroma or disease and progression, that statin therapy is initiated with 40 to 80 milligrams of Lipitor or rosuvastatin on admission, so right in the first 24 hours, and then daily for cholesterol management. And for those that have reduced left ventricular ejection fraction, that's 40% or less, and that have hypertension, to place them on an ACE inhibitor. This is particularly beneficial in those that have hypertension, diabetes, stable chronic kidney disease, and it may be reasonable in all other patients with cardiac or other vascular disease. So that's more or less their approach. This is just a diagram demonstrating much of the same thing that we just covered. The patient comes in with a STEMI, that they go to a hospital that's PCI capable, and at catheterization, and get catheterization within 90 minutes from the first medical contact. So that means from EMS contact, not necessarily arrival to the ED. That they get dual antiplatelet therapy, that's what DAPT stands for there, with an anticoagulant that's initiated, aspirin 325, so 162 to 325 technically, either Plavix, Brilinta, or Prasugrel, and then anticoagulant with either heparin or bivalirudin, and then medical therapy for revascularization according to the findings. Now, if they have multivessel disease and proximal disease, then it's a necessity to do the PC, to actually do the angiography first and then get them over to CABG and continue aspirin. But you would interrupt using Plavix and GP inhibitors as well. So that's why there's a particular division between those that may load the antiplatelet therapy, the second antiplatelet therapy immediately before, or decide to, or decide not to. But in either case, even if you gave it, it doesn't necessarily exclude you from getting CABG. It's just there's a different approach that some cardiologists have for this. Those that get primary PCI just initiate and continue antiplatelet therapy and anticoagulation, and continue general medical therapy for those. The non-STEMIs go through a similar startup when they're having continued pain that's demonstrating ongoing ischemia. And so for those invasive strategies, those that are presenting and hemodynamically unstable should have PCI within 2 hours. And so it should be immediate, right? So we've got 90 minutes on one side and 2 hours on 120 minutes on this side. So therefore, treat those similarly to any other cardiac alert. However, for those that aren't demonstrating ischemic injury, then you have within 12 to 24 hours for early intervention and within 72 hours for elective intervention. So for somebody who's been having chest pain while they're walking upstairs and they did the stress test and then the stress test was abnormal and calls you and says, I've been having chest pain again when I was walking upstairs, that person who presents ED with EKGs that don't show ST elevations, maybe shows some ischemic changes, but aren't having ongoing pain, they're not hemodynamically unstable, can easily be admitted and get cathed sometime in 3 days. But similarly, you're going to put them on to antiplatelet therapy, aspirin, anticoagulation therapy, statins, and so on and so forth. Again, the authors here stress that the timings, if somebody's having persistent pain discomfort for ischemic guided interventions, right? This is the non-STEMI, immediate within 2 hours of timing for refractory angina, new onset heart failure, worsening mitral regurgitation, recurrent angina during maximal medical therapy. It's considered early intervention. So within 24 hours, this is the 24 hours for high risk groups where they have rising troponins, new ST segment depression, so on and so forth. And then delayed for those that are an intermediate risk in the GRACE scores or TIMI scores and have ejection fractions less than 40% and post-infarction angina. These are people who may very well either have small vessel disease or have already completed an MI in the pre-hospital setting and may not necessarily benefit from emergent catheterization. And that differs from all the rest that are low risk, where we're really just doing risk stratification and determining what sort of primary prevention strategies can be applied to them. Cool. Any questions about paper number 2? All right. The third paper is looking at physical abuse of children. This is by Dr. Berkowitz. It starts off with a nice, well, not nice, but it starts off with a clinical vignette that I think is nice to always start off with. So I'll just read it to you. It's a 4-month-old male infant is brought to the emergency department by paramedics. Mother had dialed 911 because the infant appeared to be limp when she lifted him from his crib. She returned from work. She left him with her boyfriend while she was at work. On arrival in the emergency department, the infant's temperature is 37 degrees, so afebrile. Heart rate is 114. Blood pressure is 90/68. Respiratory rate is 28. And physical examination is normal except for decreased muscle tone. And there's a 1 centimeter bruise on the left cheek. How should this case be evaluated and managed? And the authors Dr. Berkowitz goes through and provides a really good epidemiology of the background of child abuse. And the focus of this study and this report is really on physical abuse, but recognizing that there's approximately 700,000 cases of child abuse annually in the US, which approaches the number of cardiovascular deaths that occur annually in the US, to kind of give you a barometer for that. And in previous years, the physical abuse has represented about 117,000 of those. But the majority of the abuse that children suffer is from general neglect, with a number of other abuse patterns that have been seen. So since this has been being written about really since 1960, it's become more of it became an academic topic and then has expanded since the early 60s. And understanding that child abuse isn't just physical abuse, that it includes sexual abuse, psychological maltreatment, medical neglect, as well as general neglect, and some other categories that are just difficult to summarize as a single category. But obviously include financial abuse and trafficking and so on and so forth that would kind of fall into those other categories. The incidence of use of head trauma is estimated to be 20 to 30 cases per 100,000 infants younger than 1 year of age. Just to let you know, that's a similar incidence that occurs with suicide when the suicide rates increase between adolescence and early adulthood. It's usually when you kind of see the initial uptick in suicide completion, particularly in men and in veterans, and their suicide rate's about that same rate. So it just gives you again an idea of like how frequent this issue is. that many of the mild cases go unrecognized, that the fatal cases with additional injuries may actually be categorized as multiple traumatic injuries as opposed to child abuse, and that the data indicates there's been some decline in abusive head trauma from 2009 through 2014, but that infants and young children are particularly at risk, and affected infants may have non-specific symptoms. And so this is kind of the important thing to just maintain a vigilance for, is that for patients that are presenting to you with brief unexplained events of bruises that have resolved, to give a consideration of possible child abuse and apnea, and those with altered mental status, those with loss of consciousness, those that have had sudden limpness, vomiting, seizure, poor feeding, or swelling of the scalp. And I'm sure we've all had different experiences with this. I've had an experience of a patient coming with new onset seizure and only discovering through the process of getting the head CT that the patient had a epidural hemorrhage from assault, with the mom present giving me a completely different story. And so the immediacy which they may present may lead you to recognizing the specific injury that they have, but the circumstances that they have is really based on maintaining vigilance on the scenario that you're seeing. So the clinical points of the stress here is that physically abused children, particularly infants, may present with non-specific symptoms and signs. That bruising on the face, neck, and torso, and intraoral lesions are important. So really looking inside the mouth carefully and looking for torn frenula is an important aspect of this. And something that I learned by reading this was to kind of go back and really look at the different soft tissue connections within the oropharynx to see if there's any evidence of tears that would suggest that somebody was slapping somebody's mouth and trying to hold their mouth shut, or twist their lips, or some form of that type of physical abuse. Was something I don't think I remembered learning before, and so it was something I took away from reading this article. In addition, that the evaluation needs to be complete. So if you have a suspicion, it needs to be a full physical exam of unclothing the patient, going head to toe, looking for skin tears, looking at the oral cavity, looking at, examining the abdomen and imaging the brain, doing a careful fundoscopic examination, looking for retinal hemorrhages, a skeletal survey and measurement of hepatic and pancreatic enzymes, because abdominal injuries may be somewhat occult and may not be as easy to appreciate, but the hepatic and pancreatic enzyme elevations would be suggestive of abdominal injuries that have occurred. And one of the aspects is also just kind of putting things into context to infants and children, and realizing, as they're going through stages of development, that there's the saying that if you can't cruise, you shouldn't bruise. And so if you can't really move around that much and fall off of things and bump into things, and you're too young to do that, and you're presenting with bruises, then those bruises are occurring because somebody is applying force to you, not because you're falling. And so those are just kind of clues to maintain your vigilance, and then just recognizing that we're mandated to report when we have suspicion of child abuse. In looking at the different fracture patterns, there are a number of fracture patterns that may or may not be related to physical abuse. And so having a non-displaced skull fracture, or having even a oblique fracture through the tibia may just be part of a regular toddler's fracture, not be related to abuse necessarily. But more specific findings for inflicted injuries are actually seeing rib fractures, and then metaphyseal lesions, or chip fractures, and or bucket handle fractures and long bones. So seeing chip fractures and bucket handle fractures is something to be is more specific that you've been injured, as well as seeing rib fractures. It's just you shouldn't be having rib fractures, particularly bilateral rib fractures. Is highly unusual, particularly for kids who have a very compliant chest wall. Any questions about that? Okay. Hold on 1 second. I'm gonna eat this for just a second. Okay, so the next article is on acute lower gastrointestinal bleeding. This is by Drs. Grauneck and Neiman and Strott, and again begins with a vignette of a 71-year-old with hypertension, hypercholesterolemia, and ischemic heart disease, who has a cardiac stent placed 4 months earlier, presenting to the emergency department with multiple episodes of red and maroon colored stool mixed with clots during the preceding 24 hours. The current medications including atenolol, Lipitor, and Plavix. And then on physical examination, the patient's diaphoretic. When she's supine, heart rate's 91, blood pressure 106 over 61. When she sits up, her heart rate increases to 107, blood pressure drops to 92 over 52. And the remainder of the examinations are remarkable, except for having maroon-colored stools on rectal exam. And the hemoglobin's 9.3 with a normal platelet count and in a normal INR. So how should the case be further evaluated and managed is the question. And the authors go through and provide a more up-to-date definition for acute lower gastrointestinal bleeding, which is defined as the onset of hematochezia originating from either the colon or rectum. So really, the idea of using the ligament of Treitz as an anatomic, border for defining upper versus lower gastrointestinal bleeding has fallen by the wayside, and it's pretty much lower gastrointestinal bleeding is colorectal bleeding, and that's about it. The causes of acute lower GI bleeding tend to be diverticulosis, up to 65% of cases, ischemic colitis, up to 20%, hemorrhoids, and colorectal polyps and angiectasias. And hold on 1 second. Sorry about that. Let me get this going here again. And then colorectal polyps and neoplasms represent a smaller proportion of this, as do a number of other features here, but important to just kind of keep this in mind, particularly structural ulcerations. That's something a lot of us forget about, and it has a high mortality if it's missed. One of the things that the authors recommend here is a restrictive transfusion policy to maintain hemoglobins of 7 or greater. So the target for transfusion is to just get to a hemoglobin of 7 or higher, and consideration of getting it to 9 or higher if somebody has clinically significant coexisting illnesses such as ischemic cardiomyopathy, or if there's going to be a context of delayed therapeutic intervention. Otherwise, the target's a target of 7. Again, the authors stress important history taking, physical exam, laboratory assessments, that patients who are receiving secondary cardiovascular prophylaxis, meaning they've already had a previous cardiac injury and they're on aspirin, that they continue aspirin without interruption. But they withhold Plavix or their other antiplatelet dual therapy anywhere from 1 to 7 days after treatment. And those patients who are high risk with hemodynamic instability, signs and symptoms of ongoing bleeding, that they require hemodynamic resuscitation with IV crystalloids and have indicated transfusion or packed red blood cells, but again, only to get to hemoglobin greater than 7. And for those that have, following that, have continued hemodynamic instability and can't consume go lightly as a colon prep, that a CT angiography is done to determine the location of bleeding and or consider a radionuclide scan for that. So doing a tagged red cell scan is another option for them. I know at Palomar we recently have a new protocol for CT angiography, particularly for GI bleeds, and so it's something that you can order now particularly for those patients that are presenting where you think that they're having ongoing bleeding. And the bleeding rate that it's picking up is not quite as sensitive as a red cell scan, but almost as. So it's almost negligible. I think there's a difference of like 0.2 milliliters per minute difference in terms of one versus the other. And that following that, again, this is a patient who's unstable to be able to undergo colonoscopy, that they can then have angiography and embolization performed. And this would be a reasonable option for them. For all the rest, if they're low risk and they're hemodynamically stable, then the priority is to get them colonoscopy. And that's the overwhelming priority over and over and over again. And even somebody who can't swallow, go lightly in that circumstance, but they're stable, an NGT can be placed and they can be given go lightly through that and taken for either upper endoscopy or lower endoscopy, depending upon the amount of bleeding and the suspicion for upper GI source that's brisk or not. So again, that first patient shows up, they're hemodynamically unstable, but they respond to resuscitation. There's a higher suspicion that there would be an upper GI bleed because of the initial presentation, and therefore an upper endoscopy would be prioritized, followed by colonoscopy performed sometime within 24 hours from the presentation, and then determination of how to go forward from there, whether or not they're going to do an endoscopic hemostasis by injecting with epinephrine and applying cautery versus applying clips and so on and so forth. Again, this management strategy with regards to cardiovascular prophylaxis is important to recognize. So those who are getting primary cardiovascular prophylaxis, meaning they haven't had a heart attack before, then you just take them off all antiplatelets and you just hold them. For those that are secondary, you keep them on aspirin, but you withhold Plavix. And then you do that for 1 to 7 days. And then you don't hold anything if somebody, so you give the dual antiplatelet therapy in somebody that's within 30 days of coronary stenting or 90 days after acute coronary syndrome, because the risks seen of major cardiovascular events is higher in that group, and it's not outweighed by the benefits of taking them off that therapy. And obviously there's other ways of mitigating blood loss by giving transfusions and so on and so forth. Again, diagnostic and therapeutic approaches are prioritizing colonoscopy with the advantages that it has a better safety profile. It's diagnostic and therapeutic. It can allow them to inject epinephrine into a bleeding vessel and then cauterize that vessel. Usually that is the combined technique of that method is preferred as opposed to any single method. And or versus doing angiography for patients who have brisk bleeding who are too unstable to undergo colonoscopy. And then obviously the disadvantages of doing that is that you may get a lesion, you may get into a vessel that's more proximal, and ischemic colon injury may result from that. Those that are diagnostic only are the multi-detector CT angio that can help become a pre-decision maker for the angiography and techniques that may be applied, and similarly the same as with the scintigraphy. Any questions about lower GI bleeding? Okay. The next article is looking at necrotizing soft tissue infections by Dr. Stevens and Bryant. This is actually a really good review article, and so if you haven't read up on nec fascia recently, I'd really recommend just taking the time to read up on this one. The authors cover the different subtypes of necrotizing fasciitis and how it's categorized, and looking at the predisposing factors for that and what the particular etiologic agents are for that. And so the first part is just that there's a division between type 1 and type 2 necrotizing fasciitis. And this is the only part where I'd be critical of the people that came up with this, where I think that they really kind of missed out on an opportunity to make it easier for all of us to remember this. because type 1 infections are polymicrobial infections, and type 2 infections are monomicrobial infections. And you would have thought that if you just would have gone enough, a type 1 and just remembering that as just a single infection, and 2 as being 2 or more, it would have been easier for us to learn this, but instead it's flipped on us, and so it's just the way it is. So again, type 1 is a polymicrobial infection. There are a number of different predisposing factors to this, and this is really the part that's difficult about necrotizing infections, is that some of them are obvious. Some of them present where there was an obvious infected injury. There was major penetrating trauma, crush or deeply penetrating wound that occurred, and they're presenting with gas gangrene, and that's typically a Clostridium infection that's presenting like that. And then there's another monocrobial infection with either Vibrio or Aeromonas that occurs in either freshwater, such as Aeromonas hydrophilia, or in saltwater, which is Vibrio vulnificus. And that's with just minor penetrating injuries. So somebody getting cut out a piece of coral in saltwater, like Vibrio vulnificus is a concern. And those that are in freshwater getting cut on a rock or something in the lake, Aeromonas is the risk, is the more likely agent. The differences between those don't really matter that much because both of those are treated with doxycycline plus additional antibiotics, but doxy is the mainstay of treatment for those. For those that are presenting with minor non-penetrating trauma, right? So this is where you get get an older person that may be tripped coming downstairs, get an x-ray of their knee and their knee doesn't show any fracture or significant injury or fusion, and you discharge them and they come back 2 days later and they're having a necrotizing fasciitis, and it's strep pyogenes that's doing that. And that's one of the real difficulties and tricks of these types of infections, is that minor trauma, even such as a muscle strain and or sprain, can be sufficient enough to lead to that type of effect. Then you have those that have mucosal breaches. Those are more seen in following birth. So rectal tears, vaginal tears, urethral tears, people getting who've had an intestinal injury, as well, will present with a polymicrobial infection. It makes sense it's polymicrobial because the nearby structures are polymicrobial, and so therefore that's what you get. And so you get a mixed aerobic and anaerobic organism seen there. And again, that differentiates from those that are just simple skin breaches, from scratching a varicella lesion or an insect bite, or maybe something more ominous with injection drugs. Those injection drugs aren't necessarily just heroin. I mean, it could just be somebody getting an IM injection, and that this is a consequence that follows. And again, these are monocrobial infections, usually with group A strep, that's causing myonecrosis. Whereas those with injection drugs, again, go back to Clostridia as the more likely etiology. And then higher risk factor groups, such as those with diabetes and peripheral vascular disease, people with cirrhosis who've been eating raw oysters, that gets you back to the Vibrio group. And then those with neutropenia, having gas gangrene, and then particularly in women following pregnancy, childbirth, abortion, whether it's induced or otherwise, and gynecologic procedures, present with strep pyogenes or Clostridia infections. And Clostridia sordeli is a really tricky bug because that's a strain that doesn't give you a fever, and so it makes it harder to diagnose that. And so the key feature to being able to make these diagnoses is a crescendoing pain pattern, an advancing quick pain pattern. That's we talk about pain out of proportion to exam, and so on and so forth. But that trajectory of a crescendo of pain is an important aspect to pick up on this diagnosis. Again, when there's a defined portal of entry, typically the entry is occurring from a skin breach or mucosal breach. The organisms come from the top down. There's an erythema and swelling response that occurs. The these organisms, like group A strep in particular, has a number of exotoxins that it expresses that causes a liquefying necrosis that occurs. And at the same time, it has metalloproteinases that are important pathologic feature that that allow it to break cell adhesion and basically act as like a biologic scalpel in going through the tissue and leading to an extreme inflammation, and platelet leukocyte aggregation occurs. And as this occurs, you start getting a DIC-like pattern and sepsis and ischemic injuries, and the ischemic bullae present and ecchymosis. And then those bullae can become more confluent with advancing edema and vascular occlusion, and then significant damage to deeper tissues that occurs. And that's in contrast to those that don't have a defined portal of entry, right? This is the trick of this, where somebody may have a non-penetrating deep tissue injury that stimulates a repair response, and then there's an influx of leukocytes and activation of progenitor cells. And then from that, there's, in patients who are susceptible with transient bacteremia, now there's organisms that are trafficked into that site, and there's this whole other process of cellular activation that still leads to the same consequence of exotoxins that are being expressed at deeper layers first. So therefore, you're not appreciating an erythema, you're not appreciating an edema as much, although advancing edema and a crescendo of pain is going to be the more likely aspect that you're going to see here before you're at the latter stages and the bullae are present, and this thing is really already taken off and spread, potentially to the torso or other layers. So those are just important mechanisms to appreciate the differences, that if there's not a defined portal of entry, you're not going to get the same presentation. And in fact, this type of presentation may even present with the patient being insensate because of early damage to the superficial nerves, and the patient not really noticing this, or is having muscle soreness and has been taking NSAID, and it's masking the pain and discomfort, and so they don't realize just how sick they are. It's a really unfair disease, and there's a lot of pitfalls here. So one of the biggest pitfalls is the absence of fever. Fever can be absent a good portion of the time in patients who are presenting with necrotizing soft tissue infection. And there's all sorts of reasons why that is, whether it's polymicrobial or monomicrobial, but nonetheless, it can be absent. And with, as I mentioned before, with Clostridia sordelli, that is the feature of that infection, is that fever is absent with that type of necrotizing infection. There can be the absence of cutaneous manifestations, just as we just kind of went through and showed you there. You could be attributing the severe pain to injury or to a procedure. So therefore, the injury that occurred previously, like I said, can appear to be minor, or it can, appear to be something that's reasonable to say, well, it looks like this, you got hurt from this reasonable injury pattern. But when the pain is crescendoing and it's worsening, and you're seeing, potential skip lesions, or seeing evidence of advancing pain and discomfort, that you've got to be vigilant and think, okay, well, maybe this could be something different, and consider this as a potential etiology. And that again, imaging tests can be really non-specific. The radiographs may show only edema, and they may not show any gas. And the sensitivity of CT scan isn't 100% sensitive for this. So the sensitivity of CT scans, in previous studies I've read, it was like somewhere in the 70s and 80s. And MRIs are more sensitive, but MRIs aren't 100% sensitive for this either. So the key feature is being able to recognize the clinical picture and performing biopsy and getting into the tissue to determine that, and getting surgical consultation is the priority. So, if a patient presents classically with swelling, erythema, pain, they're tachycardic and hypotensive, then you're checking, you're collecting a series of lab markers to also look at a predictive score like the Lorinic score, which is the laboratory risk indicator of necrotizing infections. And scoring 6 or greater on that it places you in a higher risk category for necrotizing infection versus severe cellulitis. But that Lorinic score is only really beneficial in patients that have polymicrobial infections. Those that have monocrobial infections can have such a fast trajectory that they don't develop laboratory derangements. And so that score shouldn't be over relied upon. And so I just wanted to kind of give that context. If there's gas in tissues and, then that's pretty much, go to surgery now and inspection debridement to get collection and identification based on gram stains and cultures and treatment. And so again, we have the subtypes here. Polymicrobial would be non-clostridial infections. They're usually synergistic necrotizing cellulitis that develops, and it becomes a progressive bacterial gangrene that can develop. And so you need multiple antibiotics to treat for that. You need multiple antibiotics anyway to treat for most of these. For type 2 infections, particularly strep pyogenes, you want to start with clindamycin to have a ribosomal inhibitor, and then add a drug like Zosyn and/or Recefin as well as and/or carbapenem to treat. And there's been a number of studies that have looked at different therapies to consider, adjunct therapies such as IVIG, but most of the studies recently looking at that don't actually support giving IVIG. And so while there's been a vocal camp that was supportive of IVIG, there hasn't been any strong consensus opinion that it makes a difference. So again, the priority is surgery, then followed by, in addition to additional medical therapy with antibiotics, but antibiotics really play a second role to surgical approach. And then, as I mentioned before, those that are presented with gram-negative rods are more likely to be, if they were in freshwater, Aeromonas, or Vibrio if they were in saltwater, and doxycycline is going to be an important medication to put them on up front. Any questions about necrotizing fasciitis? Cool. Next article is on non-penetrating eye injuries in children. This is by Dr. Root, Gupta, and Jamal. This article has quite a bit of information in it, but it focuses again on non-penetrating injuries. Although they start the article off by showing a couple of examples of globe rupture, and just showing kind of the subtleties that globe rupture can present with, and the irregular pupil and sometimes a choroid that's acting as a plug to mitigate the injury, and therefore not necessarily demonstrate as much of an obvious globe structural change, right? So the globe doesn't really change that much of the choroid, acts as an immediate plug. With that being said, again, this is a focus on non-penetrating eye injuries. They divide this into kind of the typical experience we have with ophthalmologists, where the emergency isn't retinal detachment or orbital fractures or traumatic hyphema and so on and so forth. The emergency issue is alkali burns, and they need to be seen, immediately for that. Immediate irrigation of the eye is necessary for that, and this paper is written from a perspective of an ophthalmologist rather than from an emergency physician. So there's a discussion of getting additional support to manage a child who may not be able to cooperate with that treatment, and electing a child services expert, I think was the term they used in the paper, which I just interpreted as Versed. That's my child expert, and Versed, and then Morgan lens and fluid, and keep irrigating until you get to a neutral pH, right? The very urgent being globe perforation and globe ruptures. And then the urgent categories being corneal abrasions, ulcers, traumatic hyphema, intraocular foreign bodies, orbital fractures, and retinal detachments. The article has some great pictures. So upper left-hand corner here shows a good picture of a large corneal abrasion. The bottom panels here, A, B, and C, demonstrate the Seidel sign, and indicating the leakage through the perforated cornea. And figure 6 here shows a good epithelial defect without any fluorescein, where you can just see this nice rounded lesion that's kind of emanating from about 2 o'clock to 5:30 on that pupil. The authors further just reiterate that if you're seeing a bunch of vertical abrasions, to consider the patient has an embedded foreign body in the lid, and to carefully inspect the lid for that. And here's an example where we're kind of right around the mid-lid here, just beneath the canthus. There's a what looks to be like a metallic foreign body. That's very small. This is contrasted with traumatic hyphema, usually seen from blood injury and bleeding that's occurring within the anterior chamber. That's graded on a particular scale based on how much of the pupil is actually being obscured by the blood that's present there. So just to let you know here, take me just a moment for my notes here on this. But the grading is a grade 1 hyphema fills less than 1/3 of the anterior chamber. Grade 2 fills half, between 1/3 and 1/2. Grade 3 is more than half, and grade 4 is complete or total hyphema. So the examples that are given here would be on the upper left-hand corner would be a grade 1 because it's less than 1/3 of that. You could maybe argue that maybe it's more than 1/3, which would make it grade 2, but it would still be less than half, as opposed to grade 4, which is in the bottom right. And so I always think it's nice to kind of know those grading scales, because it just makes it easier to communicate with the ophthalmologist following them. And the important aspect here is that when they do present with hyphema, it's important to keep the head elevated at 30 to 45 degrees at least, to promote settling of the blood in the anterior chamber. It's very important from a treatment standpoint to put an eye shield on the patient, which increases both their comfort and should be done really as soon as possible to reduce any further injury or continued, and at least continued that all the way through until the hyphema resolves. And then applying topical analgesics like proparacaine can be effective for acute pain control during the examination, and if additional pain control is necessary, giving them narcotics. And then it's also important to treat them and prescribe them antiemetics, because there'll be increased intraocular pressure from vomiting if that continues unabated. And then obviously going through and screening those patients for signs of secondary hemorrhage, sickle cell disease, hemophilia von Willebrand disease, as well, to see if a minor injury, particularly if it's a minor injury that led to this, that can be an important presentation of someone with von Willebrand disease. And then treating them with topical cycloplegics such as cyclopentolate. But all of this is going to, almost all of that's going to be in consultation at that point with the ophthalmologist. It's important to know that if you're administering a drug like that's a mydriatic, that's a potential risk factor for causing acute angle closure glaucoma in patients who already have that. And so, if it's somebody older who presents like that, this is why you definitely want to consult with the ophthalmologist before you start that. And then you may or may not consider giving them topical steroids. But again, that would be done in consultation as opposed to just doing it straight off. There have been a few other treatments that have been looked at for treating this using antifibrinolytics, such as aminocurcumic acid or tranexamic acid. And there was a review that showed that tranexamic acid reduced the rate of secondary hemorrhage after hyphema. And if you had that going on and it was progressing in front of you, that would be a reasonable thing to consider, particularly in consultation. And then treating with topical beta blockers as well to keep that intraocular pressure low, which they can have a consequence of hypertension within the eye following that. next aspect here just shows a illustration of the progression here in the top left-hand corner of alkali burns as you go from a clear cornea to a complete opacified cornea. And that can occur within the setting of minutes. And so it's why there's such an important aspect of getting them irrigated as quickly as possible. And the bottom right-hand corner just shows somebody who had a complete corneal vascularization opacification following their injury, and the obvious blindness that follows it. Those patients that are presenting with acute blood injury, particularly young patients who take a ball to the face or head, may have a complex orbital floor fracture that results in displacement and ophthalmos that occurs with trapping and diplopia that may or may not be present initially, but you may see evidence of, like on the CT scan here, where you can see that the inferior rectus is actually protruding down through the defect. Those patients may present with traumatic iritis or traumatic uveitis, which is differentiated from being not just tenderness of the iris, but also including the choroid, sclera, and optic nerve. And usually that patient presents after 24 to 72 hours after blunt trauma to the eye. And they'll say, I got hit in the eye, and at first it's, I don't know, of course it hurt a little bit, but really the next day I'm having increasing pain that's dull, redness, sensitivity to light, and you're going to diagnose that on a slit lamp by looking for the presence of cell and flare, and being able to manage that with ophthalmology by considering a dilating drops or topical steroids if they continue to have symptoms, and close follow-up with the ophthalmologist. Any questions about non-penetrating injuries? All right, I'm gonna do one thing here for a moment and just make sure that I'm gonna unmute all of you if I can for just a moment, just to make sure I'm not missing anything. I apologize, it's just one of the kind of difficulties of doing it this way. Well, apparently I can't. So I guess you guys can only unmute yourself, so I'm just assuming that you guys don't have any questions. And I don't know if there's a... Yeah, I don't have a chat box I can put up there either, so I'll just continue and we'll try to knock out the rest of these. We're making decent time. The next article looks at the changes in provider prescribing patterns after implementing an emergency department prescription opioid policy. This came out of Washington. Doctors Osborne, Williams, Vassiliadis, and Blackmore. The thrust of this was that after the intervention of a strategy, and I'll show you the strategy here in detail, that there was a 39.6% decrease in the proportion of ED visits, resulting in a discharge with an opiate prescription. Previously, about 25% of them were coming in or leaving rather with an opiate prescription. And at the end, only 15% were leaving the department with that, and that represented a relative percentage difference of approximately, anyway, 39.6%, as you can see there. In table 2, it shows the visits with opiate prescriptions before and after the intervention, and the intervention periods were similar lengths of time to each other. One was 2007 to 2010, and the next after intervention was 2012 to 2014. The reason 2010 to 2012 isn't included is they wanted to allow a sufficient time for the department to adopt the strategy, so that they were actually showing pre and post intervention strategies. And also what happened though is that their census dropped significantly in that time frame. So they went from 62,000 down to 36,000. But nonetheless, these are percentage comparisons to each other. And so again, there was a 39.6% relative decrease by implementing this plan. They saw the majority of decrease occurring in those going home with Norco and Percocet, less so with the others because those were less prescribed to begin with. So I know this is really hard to read, but I'll go through it because there's some features here that are worth emphasizing. Basically, it was a recognition that there should just be one medical provider involved in opioid treatments for a patient who has chronic pain. That administration of IV and IM opioids and AD for relief of acute exacerbations of chronic pain is really discouraged. That the providers shouldn't provide any replacement prescriptions for controlled substances that were lost, destroyed, or stolen, and that they not provide replacement dosages of methadone. These are all strategies that we already do in our place, so this is just going to seem very obvious to all of us at our side, I think, because we've adopted this type of strategy early on. The EDs are encouraged to share the visit history with other physicians and the treating and other treating physicians. That patients should send that other physicians should send patient pain agreements to the local EDs to work to include a plan for treatment in the ER, and that as we kind of go through this, that there's some issues here. They suggested that taking pictures of those who present for pain-related complaints without a government-issued ID. I don't know how well that would go over in our center, or demanding on their prescription that they have to show an ID in order to pick up their prescription. Those may be issues that are more able to be done in Washington than they are in California. I'm not quite certain. There was an aspect when they were doing the study that they were displaying placards in the ED indicating their policy, and then they got criticized as a potential EMTALA violation for doing that, so they had to take the placards down. So, you know, I know that, you know, I've got a good friend that is attending up in Seattle, and the opiate crisis was extremely severe there, and there's, you know, a large portion of the population that have opiate addiction. So, you know, perhaps their strategy was just a little more aggressive than what we might be able to do in California, or at the same time, I don't know if we could do that or not, but it doesn't seem so. And then again, no Demerol, and then, you know, it emphasized that the here that the authors recommend that if the patient needs a pain medication and they can't get to their prescriber, that they're only prescribed enough pain medication to specifically get to that office when it opens, and so that they're not given a large dose of medications for exacerbations of chronic pain. So we really minimize the total dose that's given so that they are maintaining continuity of care, and that's an emphasis here in 14 here. And they similarly emphasize in 15 that even when you are treating acute injuries, like, you know, here says such as fractured bones, that in most cases you shouldn't exceed more than 30 pills. So that, again, we're limiting the total number of opiates that are prescribed. And considering screening patients for, like, with a UTOX for opiate medication before, you know, when they're presenting. But again, there's I've definitely heard a number of different arguments on that camp as to whether or not it's appropriate to screen people for that if they're in acute pain or not. And it really comes down to whether or not you believe the patient's in discomfort or not, or if they're demonstrating behavior that's suggestive of that, then that might be a strategy to consider before prescribing. The next article looks at pediatric airway and rapid sequence intubation and trauma. It's by Dr. Sultan and Taylor. The authors first emphasize that there's a difference obviously between adult airways and infant airways, and the primary issue is that an infant's airway is more conical in shape. The larynx is significantly anterior and may make it difficult to get a good view, particularly when the occiput is also pronounced. So you have two things that are kind of working against you. You have a very anterior larynx, and then with this prominent occiput that doesn't allow you to kind of get the neck in a good position without risking potential C-spine injuries. And those young infants, and particularly in deceleration injuries, you know, such as, you know, significant car accidents, are at higher risk for atlantic occipital dislocations. And so inline stabilization is really important, and the usual measures of pre-oxygenating patients is highly emphasized, because you gotta have a ventilated patient as well as you can before you institute RSI. And so pre-oxygenation is something that's emphasized here. This is just a quick sizing chart, and this is meant because we're going to give the slides out later. So if you want to keep this slide as a quick reference, and or just remembering that all this information is on a Broslett tape or any sort of length-based tape to quickly determine what your tube size is, and more importantly, what the tube insertion length is. That's always, I think, like as important, if not more important than what your tube size is knowing how far to place the tube and recognizing that that distance is from the outward tip of the gum, not the lips. And so that you just know like what the reference point is for that tube insertion length. And then obviously, because lips are of different sizes and so on and so forth in terms of their how far they're off the face, and so the gum is is your reference point. And basically just going from both the uncuffed and cuffed versions there, from neonates all the way through to large child, and including what blade to use. And what size oral airway to also use. Usually the oral airway is just measured from the nair to the tragus. So you can, whether you're choosing a nasal trumpet or a oral pharyngeal airway. The laryngoscope blades by age, again, premature to a term neonate is a Miller 0. And then the 6-month-old to the 2-year-old is a Miller 1, and then from 2 years old up to 8 is a Miller 2, and then you can use Macintosh blades, glide scopes as well of 2s and 3s in those different age groups. If it's a difficult airway that you're having trouble visualizing and getting, then LMA is a reasonable and good secondary source. And here's the different sizes. So it's a 1 for a neonate, for a infant, it's a 1.5, for a 1-year-old to a 3-year-old, it's a 2. And then I have to think about this for a second. And then from a 5-year-old to a 9-year-old, it's a 2.5, and over 9 years of age, it's a 3. So, and the way to kind of remember that is there's like a simple trick of using your hands. So if you use your right hand and you count off odds, starting off with 1, and then your index with your thumb. So 1 is your thumb, 2 is your index finger is 3, then it's 5, 7, and 9. So you just kind of, your hand rolls out 1, 3, 5, 7, 9, and on your left hand, you just count out 10, 15, 20, 25, 30. Match your fingers up with each other and you'll get the approximate weight for that age group. So that's always a simple trick, no math involved, to quickly get an estimate based on the patient's age. Sedatives used in pediatric RSI, etomidate is generally the preferred sedative, except in sepsis, in which case ketamine is a preferred agent. For that, because there's no adrenal suppression that's associated with ketamine. Obviously, it can cause hypertension, and then there's your additional sedatives that you can consider: propofol, midazolam, fentanyl, morphine, depending upon what the patient's drug sensitivities may be. Ideal neuromuscular blocking agent is succinylcholine, and there's a different amount of, or different dose, I should say, for those younger than 2. So anybody younger than 2 gets 2 mg per kilogram, and those that are older than 2 get 1 to 1.5 milligrams per kilogram. So that's just an important thing to remember there. And rocuronium is just 1 mg per kilogram, and is and you're seeing a greater frequency of use of rocuronium being used. right, next article is on the emergency department management of pediatric shock. Dr. Mendelson here presents a really succinct and good review of pediatric shock, and kind of reminded me of going through and reading the ICU book, except for this one for kids. And the key points here are that clinical history and physical exam findings are crucial for the early recognition of the classification of shock in a pediatric patient, and really recognizing that hypoxia is a very late finding and a perimorbid state for them. So they're, that presentation of hypoxia is a very scary presentation for a kid that's in shock, because they're pretty much close to coding at that point. There's more of a classic approach here in this article about crystalloid boluses for shock, recommending 20 cc's per kilo boluses up to at least a total of 60 milligrams per kilogram before determining if there's fluid responsiveness or not. And so that may differ from what some of our local pediatric ERs practice, but just important to just kind of point out that this article is emphasizing that, and that from that perspective, just to understand that there's rapid fluid resuscitation, the first line of treatment in most forms of shock here, and that the primary vasopressor to use in children is epinephrine, particularly if they're in a cold shock, and not demonstrating signs of a compensated perfusion, but those that are uncompensated shock, unresponsive to fluids, epinephrine would be the preferred drug. So again, those presentations are categorized as hypovolemic shock, distributive shocks, cardiogenic shocks, and obstructive shocks, and can be summarized based on different hemodynamics, whether there's diminished preload in hypovolemic and distributive shocks, and increased preload in cardiogenic shocks, and obstructive shocks can be mixed, either one or the other. In all cases, the cardiac outputs decrease, with the exception of distributive shock, where you can have a mixed aspect of having a increase in cardiac output, however, not meeting metabolic need, therefore they're in shock. So they may be hyperdynamic, but not necessarily meeting their need, whereas everything else is an obvious diminished cardiac output, and where those causes can come from. And particularly in obstructive shocks, both pulmonary embolism, tamponade, tension pneumothorax, and congenital heart lesions are a frequent cause. The general classification is class 1, 2, 3, and 4 based on trauma guidelines for blood loss. And so generally those patients that are in a more severe form are presenting with severe tachycardia, central pulses are decreasing, their work of breathing is significant, and they are usually obtunded and anuric, and their skin is cold, pale, and cyanotic. And the goal is to recognize the early stages of when their heart rate's normal, their pulse is equal, their respiratory rate's normal, their mental status is normal, or maybe slightly anxious, urine output's normal, and they're warm and pink. And the recognition of that is that there's a clinical suspicion and vigilance that perhaps that's going on, right? That's the way of trying to get early on that curve before you start seeing noticeable changes in vital signs. Again, the usual doses for vasoactive medications for inotropes is to give epinephrine 0.05 to 1 microgram per kilogram per minute. If they are in if they're in a warm shock, so distributive shock, so to speak, and they have maintenance of their cardiac output, then you give Levophed at 0.05 to 0.5 micrograms per kilo per minute to start with, and that's kind of your dual approach initially, with the majority of that kind of be emphasizing epinephrine as your first drug of choice for the most part. This is just a algorithm to go through to kind of look again at the different forms of shock that somebody's presenting with, what the unique treatments are to that. So hemorrhagic shock, giving them blood products, instituting massive transfusion protocols for those in obstructive shock, it's tamponade, perform pericardiocentesis, if it's a pneumothorax, decompressing the chest tube. If they're a neurogenic shock, vasopressors with or without steroids and surgical stabilization. And obviously, there's been a lot of data that shows that steroids may not be beneficial in that group. In those with the other forms of hypovolemic septic shock, anaphylactic shock, and cardiogenic shock, that we just start to quickly go down, look at their heart rate, mental status, work of breathing, and manage their ABCs. Initiate with fluid resuscitations of getting to a goal of 60 cc's per kilogram the first 30 minutes, and considering lower boluses, particularly neonates, of 10 cc per kilogram boluses instead. And that in a fluid refractory shock, if they're cold, epinephrine; if they're warm, again, a distributor shock to give them levofed. And then if they're still in shock and not responding, to consider adrenal insufficiency and giving them hydrocortisone, 10 milligrams. Actually it varies, but giving them hydrocortisone and drawing cortisol at the same time, and instituting goal-directed therapies. And then if that doesn't work, ECMO. The next article looks at, I always have trouble seeing this one, idurcizumab for the reversal of dabigatran, or what would be easier to say is Praxbine for Pradaxa. And so this is by Dr. Gottlieb and Kashif. The bottom line of this is that they did a very good review of all the literature looking at Praxbine, and recommending that we use Praxbine when there's a life-threatening bleed that's occurring, and that it should be reserved for those serious bleeds, and that there's a low rate of drug-related adverse effects from doing that, and the drug has a very high affinity to binding Pradaxa in vitro. Its affinity is like 350 times higher than its affinity for its substrate, and there's strong evidence that it reduces the coagulation parameters, blood loss, and that there's a reduction in mortality rates. But there's a caveat to the story, and the caveat was in this other study that was called Reverse AD. The study demonstrated complete reduction in blood levels of Pradaxa concentration to the lower limits of its detection, and there was immediate correction of multiple coagulation parameters when that occurred. But the actual median time to bleeding cessation was 11 hours. And Pradaxa levels became detectable again in 6 patients at 12 hours and 16 patients at 24 hours, suggesting that other hemostatic agents may be necessary for both immediate hemostasis and a second dose of Pradaxa at the 12 or 24-hour mark may be needed to prevent its detection, its presence again, I guess would be the best way to put it. But that was, going through that was something that I looked back, from this article, I really wanted to share with you. Was just that from a practice standpoint. All right, the next article is looking at safety of magnetic resonance imaging in patients with cardiac devices by Dr. Nazarian and others, and will definitely be a paper that'll upset most of our radiologists when we start asking them about it. But the conclusions are that they evaluated the safety of MRI being performed in 1,500 patients who had legacy pacemakers, meaning these are pacemakers that were not designated to be MRI safe. And this was done at Johns Hopkins. They had a nurse who was overseeing the implementation of the protocol, who was trained in programming these instruments, as well as having an immediate hotline, if you will, to the electrophysiologist, who would also respond immediately if necessary. And so this was a highly functioning study that was done, but What they found is there were no long-term clinically significant adverse events reported with the use of doing an MRI in these legacy pacemakers. And so they did this from 2003 through 2015. Patients were excluded from participation in the study if they had undergone a lead implantation within the previous 4 weeks, if they had permanent surgical epicardial leads or permanent non-functional leads, and if they had subcutaneous defibrillator systems, or if they were pacing dependent and had an ICD without an asynchronous pacing capability. So I'll get into that in just a moment, but it's really important, like when you read these type of papers, that you really have to know the exclusion criteria before you consider proposing this on anybody, so that way you kind of know like really who you conclude, who you can't. But there were no exclusions made based on the patient's clinical instability. So that was an important aspect to this study. Their programming was the safety protocol, where it was supervised by a registered nurse with experience in cardiac device programming. Like I said, had access to an electrophysiologist who could come in right away and supervise directly. That they were familiar with the device parameters and able to look at the variables indicated lead and generator function in interaction with surrounding tissue, including the battery voltage, capture thresholds, pacing lead impedance, and sensing. So again, these are not typical things that we're going to know from our standpoint. But if we have the consultation in place, we could consider that these patients don't need to be withheld from getting MRIs, and they may be a more important aspect for the inpatient care. But also understanding that some of these patients may not necessarily be discharged and may be admitted to get their MRI undergoing a particular protocol like this. And the device is reprogrammed. This is an important aspect to it. The device is reprogrammed to an asynchronous pacing mode for patients who are dependent and who are pacer dependent. So those that have heart rates less than 40 beats per minute, they're reprogrammed to an asynchronous pacing mode, so they're constantly getting a pace at least. And then everyone else has an inhibited pacing mode, and that includes pacing features and functions that treat tachyarrhythmias, and including a full magnet mode of a programmable feature that blocks all of those tachyarrhythmia responses. So they did 2,100 MRIs in 1,500 patients, and 1,509 to be exact. And they looked at various different aspects of whether or not it was a right atrial lead, a right ventricular lead, the left ventricular lead. It didn't matter. The safety profile was seen, but you can see what the percentages of those lead presentations were there. What they did find was the most important adverse effect that they found was that the device would go into a power on reset, which would allow it to go back into pacing and doing some tachyarrhythmia treatments, which could result in some problems. So there were 9 patients out of the 1,500 that had that occur to them. Only 2 of them did not receive their scan. One of them because they felt a pulling sensation in their chest during the MRI, and the other one was aborted because it started pacing. It basically had started pacing and resulted in a brief pause after the power on reset, so they stopped on that patient. But otherwise, everybody else completed their study and they just got reprogrammed. So in the discussion, they basically demonstrated that a large prospective study, they evaluated the safety MRI with implanted legacy devices and found to be, and the most important event that was found to be attributable to an MRI was the occurrence of this power on reset. But it only occurred in 1 in 200 examinations. And during those events, the device was susceptible to inhibition of pacing output and activation. But as you saw in the review of those 9 MRI examinations, nothing significant occurred. And then of those patients that, they want to point out that it's vital to emphasize that the need for appropriate device programming, monitoring by a qualified person, and ability of an external pacing backup for those patients is important, right? Like putting them on asynchronous mode is fine, but if the device just stops, you need to have an available external pacing backup in order to treat them. So it's just it's an important caveat to be able to carry a program like that out. And if the power on reset occurs, the device just resorts back to an inhibited pacing mode, and that pacing dependent is just transiently ceasing pacing because of the electromagnetic interference, and so those patients are maintained on a continuous monitor and pulse oximetry during their scans. All right, I think the last article, actually there's two more articles. This next article is acute spinal cord compression. It's by Dr. Ropers, and this looks at the various different syndromes of acute spinal cord injuries, looking at everything from spinal shock to central cord syndrome to Brown-Séquard, conus medullaris, and cauda equina syndrome. I would only just draw attention to conus medullaris because it's a syndrome that I had to read up on again to be familiar with. That's cord compression at L1, L2 vertebral bodies. That's seen with weakness of the feet and legs with variable reflexes in the legs. And there's loss of sphincter function and loss of sensation at the sacrum and lower lumbar and perineal regions and those dermatomes. And they may have variable Babinski signs, so it's a tricky one to be able to pick up on. Those that are presenting with acute traumatic injury, such as jump facets and acute fracture with retropulsion of the fragments, require surgical intervention and reduction. There is very little, if any, support for steroids in those patients, and that really contrasts to another entity. When we get to that, I'll tell you. But in the patients that are presenting with traumatic spinal cord injury, they're graded. Again, these grading scales are helpful to at least understand that grade A is complete, so there's no sensory, no motor function is preserved. Grade B is a sensory incomplete, so there's sensory but no motor function that's seen. Grade C is motor incomplete, so there's motor functions preserved at most of the caudal sacral segments for voluntary anal contraction and sensory functions preserved, with some sparing of motor function more than 3 levels below the motor level on either side of the body. And then D is a motor incomplete, which is muscle power, motor function is incomplete and defined above, with muscle power greater than 3 for at least half of the key muscle functions below the neurologic level of injury. And part just worth mentioning here is that the level of injury is defined as the area where you have maintained function. So wherever you have maintained function, that's where your level is. And then everything below that is understood based on where you were maintained to for your normal sensory and motor functions. So four major entities are discussed here: traumatic cord compression, neoplastic cord compression, spinal epidural abscess, and spinal epidural hematoma. In all of these cases, the main treatment options are surgical, right? That's pretty much the focus of it, with a slight exception to neoplastic cord compression. Depending upon the type of cancer that's causing cord compression may define whether or not there's a particular strategy to it or not. Some forms of tumors are more sensitive to radiotherapy, and so therefore radiotherapy may be the initial primary treatment. In addition, what differs about neoplastic cord compression is that steroids here are indicated, and particularly high-dose steroids are indicated for that treatment in combination with radiotherapy and or radiosurgery. And then there is a more complex decision made about whether or not to perform any surgical debulking, depending upon how much of the vertebral structures are involved. And if it's circumferential, the removal of tumor may be really difficult. Laminectomy is not going to be like the only way that you go at this, so you would have to do a circumferential removal, and that may lead to greater spinal instability. And so that's, again, why the decisions here are not as clear-cut with neoplastic cord compressions, as opposed to traumatic cord compressions, spinal epidural abscess, and spinal epidural hematoma, in which case surgery is the mainstay in all of those settings. And again, the neoplastic, you may start with steroids first and then have consideration of consulting with rad-onc and figuring out whether or not this, radiotherapy would be preferred versus radiosurgery or some other form of minimally invasive surgery for a surgical approach. Again, while antibiotics are an important adjunct for patients with spinal epidural abscess, surgery is the main therapy there, and obviously with cord compression, the medical therapy is just to maintain blood pressure to avoid neurogenic shock, and to determine if they're incontinent or retaining for a prognostic standpoint, and if they've been paraplegic for how long, or sorry, if they've had anesthesia of any sort for how long they've had it, because once they get to 72 hours, it's very difficult and unlikely that they're going to recover significantly from that at that point. Again, this is just an example of how a metastatic tumor can grow from the vertebral body and compress the spinal cord. You're going to treat with steroids first and then consider radiation therapy depending upon which type of tumor it is. There are a number of tumors that are radio insensitive. Renal carcinoma is an example of that. The treatment here is radiotherapy. Surgical decompression is only partly palliative, but there can be relief of paraplegia and reduction of pain with surgery. And vertebral infiltration with the tumor may not always compress the cord, but can be managed with radiation in those that are radiosensitive. A good learning lesson for the acute compression due to epidural abscess is just a physical exam technique of percussing the spine. There are a lot of really good older papers that continue to hold up even now, that percussing the spine is a good way of picking up on epidural abscess, and would be something good to document when you're concerned about that. And then the last paper is on thrombectomy for stroke at 6 to 16 hours with selection by perfusion imaging. This is by Dr. Albers and others. This was a study looking at endovascular thrombectomy for ischemic stroke from the 6 to 16 hour mark after a patient was last known to be well. And so not on presentation, but last known well time, anywhere between 6 and 16 hours. And a combined approach of endovascular thrombectomy with standard medical care led to significantly better functional outcomes than standard medical therapy alone, so than just TPA alone. And in those patients who had proximal middle cerebral artery or who had internal carotid artery occlusions. So these are large vessel occlusions that are seen, and they're seen on a perfusion imaging approach. So the ages here were generally, the median age were in the 70s. The stroke scales were reasonably high at 16 as a median. Many of these patients had, up to 34 to 40% of them had witnessed strokes, but a lot of them were unwitnessed and were wake-up strokes. So over half of them in the endovascular group were wake-up strokes, and nearly half of them in the medical therapy group. And again, the endovascular therapy group is endovascular therapy plus standard medical therapy versus standard medical therapy. So this is a typical kind of like phase 2 trial that would be done. An important aspect of this is that the perfusion scan's done and chosen because it gives you a ratio between the amount of at-risk tissue versus that tissue that has already demonstrated injury. And so usually the at-risk tissue to injured ratio is 1.8. And so that's going to be calculated from performing the perfusion scan. And so again, it's ischemic tissue versus infarct size. And so there has to be tissue to reperfuse and a sizable and enough of it that it's worthwhile to do this. And so following folks where they hadn't had a significant anoxic injury to the point that that it didn't look like it would be reversible, they found significant improvements in a side-by-side comparison. So The modified Rankin score is a score that is an inverse of your outcome, of your proportional outcome. So 0 to 2 is considered a good outcome. 5 and 6 are terrible outcomes. And so the intravascular therapy was associated with about a 47% improvement of good outcome versus just 16% in the medical therapy group. So this was a significant improvement in care as a result of that. Again, they're partially biased in the fact that you're choosing ones that have large vessels that are blocked with a lot of viable tissue left to reperfuse. But in either case, this was a randomized study between one versus the other, and in that study there was a significant difference here. So again, the primary efficacy outcome was a median score on the modified Rankin that was lower, so better improvement, and the odds ratio was 2.77. Functional independence was seen in 45% of patients versus 17% of patients in medical therapy. And death at 90 days was reduced as well. And so, so this is something that has really influenced current stroke management, and that's why we're moving towards a stroke management protocol where stroke codes may be called within the first 24 hours instead of just the first 6 hours because of this treatment window of 6 to 16 hours that's seen. All right, that's it for the articles. I'll stay on in case you have any questions, but thanks for your attention and for participating. I really appreciate it.